Good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please enter your questions in the chat at the end of the presentation. And please answer a brief survey that will be made to you available to you immediately after the presentation. And finally, our speaker today is from the Division of Physical Medicine and Rehabilitation. And I'd like to invite the chief of that division, Dr. Mohan Radhakrishna, to introduce our speaker. Mohan, thanks.
Thank you, Nadia. Hello, everybody. Thank you for attending. So today, Dr. Jessica Thériault will be presenting. So Dr. Thériault, after finishing her medical school at University of Sherbrooke, did a residency in PM&R at University of Laval, followed by a fellowship in EMG and neuromuscular diseases here at McGill. She's also done some extra training in neuromuscular ultrasound in Europe. So it's always interesting to have her on board with our team. And so, Dr. Thériault, please come and teach us about neuralgic amyotrophy.
Thank you for everyone attending today. Thank you for the kind introduction. Yes, I hope you can hear me well. Today, I will present about neuralgic amyotrophy, which is a fascinating condition and my point of view in which I think everyone, including patient and clinician, will benefit to gather better knowledge and recognize earlier for optimal management. So this will follow a classical outline for medical presentation. And we will go over the clinical presentation, investigation, and management required in this type of condition. At the end of the presentation today, I hope you are able to recognize the typical characteristic of this clinical presentation in the acute and its chronic complication, conduct a targeted physical examination, request the appropriate investigation and recognize their limitations, and initiate treatment appropriately or involve the multidisciplinary team required to treat this condition. This condition is quite intriguing to me, fascinating. We believe it's still recognized and underestimated as a cause of chronic shoulder and neck pain. But it starts really in the 1900s, where there were reports of viral epidemics associated with severe shoulder pain and scapular winging. But this wasn't really well described until 1972. Dr. Parsonage and Turner described this clinical entity. Therefore, you can sometimes hear that this condition is also called Parsonage-Turner syndrome, as well as neuralgic amyotrophy, and there are other terms used as well, including idiopathic brachial plexitis, which is a bit inaccurate. We'll see why later. And with the rise of imaging, this condition is later found to be much more extraplexal than it was initially thought. And they were able to merge this condition with other conditions previously seen by plastic surgeons. When we take a look at the incidence of the disease, this incidence was reported based on the prospective studies in 2015. I found it quite surprising. In these prospective studies, the incidence of the disease was as frequent or even more frequent than cervical radiculopathy. To obtain this high elevated incidence, Dr. Van Elfen conducted a prospective study after educating primary care provider involved in the study about this disease by mainly teaching them about clinical symptoms and the physical examination. And at first, the initial incidence was thought to be 1 or 3 in 100,000 people, and ended up to 1 in 1,000 people. So there was quite a few undiagnosed cases, and quite some delay in diagnostic also for these individuals. And we believe that the prompt recognition can lead to better care and better use of our resources. So I will review right now with you what are the classical symptoms for this condition and common differential diagnostic that we need to consider. So the classical presentation will occur in 70% of cases. This will always almost start with very severe pain around the shoulder area. This can involve the upper arm or the forearm. This will be usually followed after a few days by abnormal shoulder movement, unable to lift the arm overhead. And this will involve a paresis of very specific nerves that are usually not involved in other disease, like the long thoracic nerve, which leads to shoulder winging, the suprascapular nerve, which is responsible for innervating the rotator cuff, and we can see as shoulder external rotation weakness, and the anterior interosseous nerve, which leads to a deficit in the flexion of the deep finger flexors, and it's usually detected by the OK sign. So really, if you have this typical presentation with this stereotyped neurological deficit, you can be quite confident that you've encountered this disease. This is really where the money is. The main differential diagnostic and what people will be most often misdiagnosed as is cervical radiculopathy or rotator cuff disease. We can see a few characteristics here that can help differentiate the two conditions. In general, cervical radiculopathy pain seems to be less intense than the pain that individual with neuralgic amyotrophy encounter. And for the cervical radiculopathy, the pain is usually more distal. Most common route involve are C6, C7, so they will involve the forearm and the finger. And in neuralgic amyotrophy, the pain is usually more around the shoulder area. In cervical radiculopathy, there should be pain with specific neck, reproduced with specific neck movement. And NA, this would be more with shoulder movements, or even just spontaneous or at rest. I must say there is variability in the clinical presentation, but one thing is almost always there, and it's the pain. Other than that, there is more frequently weakness, but there can be paresthesia, sensory symptoms as well, although they're usually not the main features. And to complicate even more, there are possible other nerve involved, but I would say for the essential of this presentation, we will remain targeted on the main nerves that are usually involved. And just as a reminder, this is a brachial plexus, and so like I said earlier, it used to be called a brachial plexitis, but in reality, this is not a brachial plexitis. This is only some nerves or some region of the brachial plexus that can be involved. And this may seem irrelevant to you, but when we conduct electrodiagnostic testing and we try to localize the lesion, it's really important to define this. Figure A is a more typical involvement with the lateral cord, suprascapular nerve, and long thoracic nerve. And figure B would be more a typical presentation with the lower trunk involvement. In neurology, they usually like patterns. So the pattern of this disease is a multifocal neuropathy. Most often, it could also be a single mononeuropathy, but this would involve nerves that are usually not involved into compressive syndrome or at locations that are at non-compressive sites. And this is the scope of all the nerve that has been described as potentially involved in the disease. Some are very distal, and some here we found the typical one that I've described earlier. One nerve I would like to mention to you, as you come from a different background, is that there's potential involvement of the phrenic nerve. This could be unilateral, but this can also be bilateral. Even though rare, you can understand that this has some consequences of the person affected by this, including dyspnea, orthopnea, nocturnal hypoventilation leading to daytime sleepiness. Here are tests that you could do to try to detect to study the diaphragm strength. I would say I really like the sitting and supine force vital capacity. If there's a difference between sitting and supine of more than 500 milliliter, it's positive. Other imaging tests that have good diagnostic value are ultrasound of the diaphragm to detect atrophy and regular X-ray that can show hemidiaphragm elevation. I'm not going to go too much into detail. I'm not a pathologist myself, but I think it's really, it's still under research and hypothetic, but what we found is that there's some individual with hereditary predispositions. Most individuals, they have risk factor like AV labor, and they have some sorts of triggering events triggering the immune system reaction. So it is an autoimmune mediated process against some part of the axons that's usually protected by the blood nerve barrier, and for some reason the blood nerve barrier is disrupted, and this can allow the peripheral immune system to attack the nerve components. Together we just saw that there is a sudden onset, and there is an acute phase where weakness developed. Over time, there will be some level of neurological recovery. And, many people are diagnosed in that phase, unfortunately. So there will be some partial neurological recovery with persistent complication that can arise as chronic shoulder pain and abnormal shoulder movements that are resistant to standard physiotherapy. And often that's why they look for care, specialized care. So I know this might be quite out of your scope. I try to make it as simple so you can still appreciate if ever you see a patient like this. I think one thing that it's important to realize is that the scapula is an important bone that helps us orient our arm into the space, and it moves along 3 axes to allow this movement. It's a very complex movement. And this coordination of the scapula can give rise to injury to tendons, therefore a reason why people are not diagnosed appropriately. A good way to start looking at the scapula, well, you need the patient undressed. You can use your hand to localize the inferior and upper scapular spine, or some people might prefer taking a step back or even take their phone to look at if the scapular movement are symmetrical. In general, what we see during a scapular movement is that the scapula needs to rotate upward to allow the glenoid to face up, and it needs to tilt backward and externally rotated slightly. These are examples of quite severe scapular winging. What is interesting is that scapular winging and scapular dyskinesia can be very similar and very hard to distinguish. I do not think that most of you need to make the difference. Just to note that there is abnormal scapular movement should trigger a referral. On the left, the abnormal scapula is on the right. This is caused by the muscle serratus anterior palsy, which arises as a consequence of the long thoracic nerve paralysis. And on the right of the screen, this is the left scapula is the abnormal one. And this is caused by a trapezius weakness. Trapezius is innervated by the spinal accessory nerve, cranial nerve 11, and some part of C3-7 root nerve. Both, what they have in common is that they cannot both elevate their arm because their muscle cannot rotate the scapula appropriately upward. This is a useful test to detect serratus anterior weakness, which frequently arises as a consequence of the neuralgic amyotrophy. One way that you can even detect also dyskinesis or true paresis. So the tango test, or the stop sign, I call it to my patient. I simply do a stop sign and have a little push against the wrist of the patient. If they can keep their scapula stable over their rib cage, their muscle is strong. If they can, there can be either a dyskinesis or a true palsy. And then to distinguish a true palsy than a dyskinesis, you have the elbow bent, and you just push against the elbow, and you see if the patient can resist by keeping the scapula shouldn't move. If the scapula moves, that is there also is a weakness. And the reason why there would be a weakness on the picture on the left and no weakness on the picture of the right is because pointing forward or extending your arm is an automated motor pattern from your brain. If for some reason this automated pattern is lost because of pain or because of the primary neurological injury, your brain's going to use another pattern to do the same thing. When you do a new movement that your brain never did, then it can activate the muscle correctly. Other muscle, like we said, shoulder extension, rotation weakness. So you keep the elbow along the torso, and you can resist the opening of the forearm of the outside to test shoulder external rotation. We just mentioned serratus anterior. Elbow flexion is worth testing, and the famous OK sign. So in case of a positive sign, patients are not able to maintain the round shape. There would usually be a flattening of the distal interphalangeal joint, or your finger would pass through. Complementary tests to rule out differential diagnostic would include a cervical examination to help with cervical radiculopathy, a shoulder screening testing to evaluate for shoulder rotator cuff injury, a more complete neurological injury, and some special tests can be helpful for differential diagnostic like thoracic outlet syndrome, or thoracic outlet syndrome can also be a consequence of shoulder dyskinesis. Now, like I said earlier, at this point, as a specialist, I'm most likely to see patients in their chronic stages, because on the acute phases, they will usually go to the ER or primary care provider. But at their chronic stages, they can present with refractory impingement syndrome. When I mean refractory, meaning that they're worsened with the typical physiotherapy programs. They can have capsulitis, myofascial pain syndrome due to overactive muscles around the scapula. They can have thoracic outlet syndrome, usually from under the pec minor muscles, nerve compression or irritation. They can have overuse pain of the contralateral arm because their right arm is limited, or muscle fatigue and low endurance due to the process, the neuralgic recovery process itself. When nerve regrow, it doesn't necessarily regrow from itself. There's a process called axonal sprouting in which the neighbor axons take over. Therefore, the total number of axons is reduced, and that can lead to, yes, normal strength and recovery, but a slightly less endurance. A few studies have looked on the prognosis of these patients. So 70% does not recover successfully enough and remain with persisting chronic pain around the neck and shoulder area. Up to 1/3 will have to change their job because they had some physical labor and the lack of endurance would not allow them to complete the previous task. And they can have secondary condition due to the scapular abnormal movement, including shoulder impingement syndrome and thoracic outlet syndrome. At this point, some of them will be labeled as a chronic pain patient or have a psychological dysfunction because of the unevolving rehabilitation process. Let's say we've had a case, someone had presented to you with the typical presentation. What I would usually offer as a follow-up, because there's still good chance that there's neurological recovery happening, you can follow up in the first 3 months and see if what type of recovery they have. At 3 months, if there's still persistent weakness, it's usually a good timing to perform electromyography. The electromyography is going to be mostly used for prognostication and decide on potential surgical care. And at this point, also imaging could be considered for the same reason, for prognostication and decide on surgical care. So a few words on the usual diagnostic test used for this condition. MRI. MRI, what we need to remember is that most lesions are not in the plexus. They would usually be in the upper arm when it comes to median nerve, and then depending on the specific nerve. So you need to be careful to the region you ask. You rarely have to image the whole. You rarely ask for MRI of the whole neck to the arm. So you have to be more specific, which can be challenging in this condition. And there is a danger into asking too many cervical MRI, including the high rates of false positive. What I see usually happens is that if people have a documented foraminal stenosis, people are, there you go, I have the diagnostic, I stop looking. And another interesting modality that has raised in popularity is high resolution ultrasound of the nerves. There are specific findings, and some of these findings are linked to poor prognosis, like hourglass constrictions and fascicular torsions. But once again, there's a limitation for this, which is some nerve underbones are not visible. And then for nerve conduction study and electromyography, there's a limited sensitivity of this diagnostic test because most people use protocols, and the neurological problems might be outside of the protocols usually used in centers. For nerve conduction studies, the timing matters. If you ask it too early, we might not see much and there will not be relevant information. So it usually needs to be repeated anyway at 3 months. The muscle sampling affect the sensitivity, and it's also, it can be hard to differentiate from a cervical radiculopathy without a full muscle sampling, which is usually more detailed, and once again will depend on the clinician. So yes, it will still be useful and require and important for the prognosis in the end. These were just to see potential finding on ultrasounds. The most common finding will be a nerve swelling. There's now, many published cross-sectional area of nerve, and it is quite straightforward to diagnose a nerve swelling. There's potential constriction. They can be incomplete constriction or complete constrictions. You will kind of understand that a complete constriction of a nerve it's a little bit like a nerve injury. So this will not recover well. And then there's described fascicular torsion. If you remember at first in the presentation, I mentioned that surgeons were seeing that in their clients with nerve pathologies. So here, I don't know if you could see it well, but there's really an area of constriction within the nerve. This is, we believe it's either perineural bands or fibrosis subsequent to the nerve swelling and inflammatory reactions. And yes, these are perioperative pictures where we can see after opening the epineurium that the nerve is literally turned on itself, which is also not linked to a good prognosis. It needs to be operated. So in summary, monitoring is needed for this condition. Usually will include at least one imaging and a nerve conduction study. Nerve surgery is outside the scope of this presentation, but what is important to remember is there is a narrow window of time for nerve surgery, which is between 6 to 12 months. So we need to be fast in identifying cases that would benefit from it. Complete hourglass constrictions and fascicular torsions are a finding on imaging indicating a poor, associated to a poor prognosis of neurological recovery. Maybe more relevant here for general medicine is that there are some evidence, unfortunately not from randomized controlled trials, that very acute use of oral corticosteroids can help the prognosis and definitely helps the pain control. The pain is quite severe and refractory. Usually NSAIDs will not be enough for that type of pain. The expert that I was in contact with would usually recommend 1 week of 60 milligram prednisone, then a taper on the second week to completely stop after 2 weeks. It's really difficult to catch them early on. However, there are people that will have recurrent attacks, and they will usually leave a crisis prescription for these individuals. I was mentioning earlier, we'll discuss management here, more multidisciplinary and rehabilitation, but I was mentioning earlier that typical physiotherapy protocols were often failing in this population because it failed to address the abnormal motor control caused by the abnormal neuroplasticity, and tend to instruct for stretching and strengthening and reinforce the abnormal motor control. Therefore, in this case, coordination of the scapular muscle is more important than the reinforcement. I also said earlier that residual fatigue is normal and expected and should be respected by proposing intervention like energy conservation technique and pacing. The occupational therapist will usually be the one proposing this approach and helping individual find adaptations, and also teach them on effective rest of the shoulder, which can sometimes needs to be supported at the end of the day. And like many conditions in rehabilitation, education of the patient will lead to better self-efficacy and self-management and better improvement. These are more specific, but a study had shown that multidisciplinary care approach that was individualized to patient was superior to the usual care, which would involve strain training. This we mostly discussed earlier. This was a slide length, but this is a Delft tile. It's something very typical in the Netherlands, where I just been training, and they give tiles like this to patients, reminding you that you can do anything you want as long as it doesn't hurt longer than the amount of time you did it. And finally, surgical care. As a rare condition, there's limited literature. But in general, they tend to have a better prognosis in the individual that had the hourglass constriction or the torsions, with either just release of the torsion and fixation of the nerve. And in some case where recovery was not proceeding, they would need nerve transfer to palliate the loss of a nerve, sometimes also requiring tendon transfer. So plastic surgery should be involved in the care of these patients. The challenge of surgical care is to identify who will benefit from it, and to identify these patients within the correct time windows. And do not remember that monitoring of nerve conduction study and EMG is important to identify these patients. And there are tons of described procedure, but once again, I think this go too far for the scope of this presentation. So to summarize, neuralgic amyotrophy is a condition that can be recognized based on its typical clinical presentation involving severe pain, abnormal shoulder movement, and patchy weakness in one arm, asymmetrical. Individual may present with the complication rather presenting as a shoulder impingement syndrome or thoracic outlet syndrome. So you may dig in a little bit to see if at some point they did presented with the acute and severe shoulder pain. imaging and nerve conduction studies and EMG are complementary investigation to identify individual who could benefit from surgical care. I believe a long-term follow-up is required to ensure the optimal management, neurological recovery, and address secondary complications. And finally, multidisciplinary rehabilitation team should be involved for optimal management and patient education.
Okay, thank you very much. Okay, thank you very much for this very comprehensive review on a fascinating topic that I'm sure many of us, including myself, didn't really know anything about. There is a question here. David Rosenblatt, do you want to unmute yourself to ask your question?
I could, but it's
Yeah, go ahead. Yeah.
a pretty uninformed question. I just want to know if there's any overlap at early stages with the pain of frozen shoulder. Is that in the differential at early stages?
Yeah, so I think there can be an overlap into the presentations. I agree with that. Because at the early stage of frozen shoulder, you cannot tell that it's frozen shoulder and the pain is usually at night. So it will definitely present in a similar fashion, unfortunately.
Okay, I'm just going to take a question from the floor. Do you want to just come a little bit closer? Yeah.
Hi, it's Dr. Flagel here. Is there any association with other chronic diseases, in particular with diabetes? That's the first question.
Yes.
And the second one is, has anybody done any studies on the nature of the autoimmune attack, like the mechanism?
Yes, I chose to stay away from the mechanism because I'm not too well. I would have to revise a bit of the immune process. I know this is not perivascular attacks, and these involve lymphocytase CD8 infiltration within the nerve, but my own knowledge stops there. And in terms of, and it's also very often associated with some specific virus. In Europe, they have hepatitis E virus, often preceding the attack, which is very unspecific symptoms of myalgia, basically, and general fatigue. And then, no, it is not associated with type 2 diabetes, surprisingly, because many nerve problems are, but this one is not. And it can also present into the lumboradicular plexus in similar fashion to diabetes.
Okay, there's another question in the chat. Why is it confined to the brachial area? Just a little bit more on that.
Mm-hmm. So indeed, the current hypothesis is the combination of the mechanical stress onto those nerves. But there are cases, and once again, it's case series or case report of lumbosacral plexus involvement.
What can we do practically speaking if we suspect one of our patients at the MUHC has this condition? What would be the approach we would take?
Yes. So the easy one is to refer or contact a neurologist involved in neuromuscular diagnostic. I mean, I'll be happy to be contacted as well, but I understand that I'm not maybe as accessible as a neurologist.
Okay, so we start with neurology and, oh, sorry, go ahead, Mohan.
Thanks, Jessica. I guess I have maybe two questions. One is I was very surprised about the epidemiology because, I see a lot of cervical radiculopathies. I've seen a few neuralgic amyotrophies. And I'm curious about that part. Is it because people are not seeing this at all, or because there's a gradation in the severity? A true winging scapula is pretty easy to see. You can tell that quite easily. I've seen a lot of mild scapular dyskinesis where we're like, oh, maybe just muscle imbalance.
Yes. So you're absolutely right, because they do. That's why I showed that slide where there's a neurological recovery happening, and we potentially see these patients once they have already partially neurologically recovered, and the damage is often not that severe. So in cases that I've seen while I was in Europe, the weakness was mild and more presenting with shoulder dyskinesis and lack of activation of their serratus anterior and subtle AIN weakness, maybe on the order of 4 out of 5. That could easily not be judged significant by people not aware of the condition.
Thank you. A second question. When I've seen these patients before, I had 1 or 2 patients in particular where because of the scapular weakness, they get this winging and that tilts the glenoid, which then causes rotator cuff pain.
Mm-hmm.
And you can do this physical examination. What I'll do is I'll push on the back of their scapula, push it against the rib cage, and all of a sudden they lift up their arm in the air.
Yeah.
And so what I did is I prescribed them a brace, which is really cumbersome, but they seem to help them at least. I'm just curious whether they had any experience of that in Europe.
Yes, they are actually developing a brace that could be more suitable than those already available over the market, because, you know, braces are prefabricated and are not suitable for everyone. That was their comment about that.
There's a comment in the chat here about post-West Nile virus outbreak. Any comments on that?
And wait. It was during the West Nile virus. Yeah, well, I would say that this definitely is possible that this could have been a presentation like that. There's other differential diagnostic, and it's also complex neurology, but I would definitely consider that diagnostic. Yes.
Okay. Are there any other questions? If not, thanks everyone. Thank you. Very interesting presentation. We'll close the rounds. Thanks everyone. Have a great afternoon. Bye-bye.